So I would like to thank Francisco and Dr. Kozin for the invitation to this PULM session. So my topic today is Madelung deformity in 2020. What's hot and what's yet not. So I would like to give an overview of the literature so far about this very interesting topic and deformity. So here you can see an image of Madelung starting my session. So actually, Madelung was not the first person who reported about this deformity. Originally, Dupuytren was the first one, but Madelung was the first person who really described in more detail this deformity, which accounts for about almost 2% of all the malformations according to the Adrian Flett book. Females are more often with this deformity compared to males. Bilateral occurrence is very common. And very often there is a dyschondrosteosis lesion, so-called Larry-Weil syndrome associated with this deformity. And the Madelung deformity is caused by a SHOX gene mutation, as you may well know. And furthermore, a gene S mutation has been found recently as well as one of the causes for Madelung deformity. So there is an ongoing discussion about the causes and the etiology. So here in this French paper, 12 patients have been evaluated, and all were syndromic cases, so with a SHOX mutation, 9 of which had a Larry-Weil syndrome, 3 had a Turner syndrome. So this is another very common syndrome in this deformity. But there is still the discussion whether there exists an isolated form of Madelung deformity, which might be like a minor phenotypic form. And also here in this Chinese case report, there has been found just a single base deletion at a special gene, 21, of the SHOX gene. So there might still be the cause that it exists a minor form, and I can still agree with this finding based on my clinical overview of cases, but I will tell about this afterwards. So concerning the pathology, we have the Vickers ligament, which is a thick fibrous radiolunate structure consisting of collagen fibers and also some elastin. And moreover, there's a dorsal sided part of the Vickers ligament. It's the radiotriquetral portion of it, or whether it's the same ligament or another ligament is still ongoing discussion. But nevertheless, we still do not know clearly whether this is the cause or just the sequelae of the deformity. Most of us expect that it's the cause, but actually it has not been proven so far. So here on these images, you can see the Vickers ligament very nicely. It tethers the radius to the lunate, to the triquetrum, and also some fibers go on to the ulnar head, as you can see here. And on the image D, with the arrowhead, you can also see the dorsal sided part, which refers to the radiotriquetral part of the ligament. So we just had a nice paper accepted in the Journal of Hand Surgery European, where we did an international report on actually the largest Madelung series so far. And we have seen that 83% had an intraoperatively detected Vickers. So not all cases, and this was the purpose of the study, that some of us have seen cases with no Madelung intraoperatively, and that's why we performed this study. And interestingly, almost 3 out of 4 had a distal radius notch in the radius. We can speak about it afterwards. And especially those Madelungs with a whole bone type, so where the whole entire forearm was affected, and those with a distal radial notch were those Madelungs which had a Vickers ligament present during surgery. So these are the predictors for a Vickers ligament. So actually the positive predictive value has been shown to be 93%, but the negative predictive value only 43%. So it's a very interesting paper, and it should come out next week actually. So how about the physis and the whole structure? So the number of the chondrocyte columns has been changed in Madelung deformity. So there's no horizontal, so no vertical progression, it's a horizontal progression. The chondrocytes are stacked side to side, as you can see, for example, here in this part. And they're like chondrocyte nests, so it's not a regular structure in the physis in Madelung patients. And so, as you are well aware, there is a closure of the ulnar-sided part of the distal radius. So you can see it actually over here. You can see a severe form with the closed physis part over here, but there are also mild forms, which are under discussion. And you can see here also in the image C, the closed physis on the ulnar-sided part. So this is a discussion. Is it actually a mild Madelung form or not? Here you can see the so-called notch, which we spoke about just before. So there's some kind of indentation of the radius over here, but sometimes there's also a small spur, which you can see here. So this might be the origin of the Vicus ligament. So how about this, the clinical features? You have a short radius with a tilted and palmally tilted plateau. You have a radial bowing of the forearm with a consecutive relative ulnar overlength, subluxation of the carpus, a V-shaped carpus eventually, and all of these features can lead to pain, functional impairment, and aesthetic deformity, of course, which is very often the main feature for the patient, especially the young girls, when they come to your office. So here you can see actually a case with Larry-Wald syndrome, a short-statured girl with the bowing of the forearm, a subluxation, so-called bayonet position of the wrist. And as I mentioned, these cosmetic issues are very relevant. The forearm function has been lost, especially prosupination, wrist extension. And very often these patients have also chronic pain. You can imagine here when seeing this arthroscopy video of my mentor who did it several years ago, that this might be a cause for chronic wrist pain as well. And with this regards, we checked our patients with chronic wrist pain several years ago, and we have seen that the Madelung cases were actually those ones, a very large group with chronic wrist pain in our series, and actually all of them had also TFCC tier. And this was some kind of predisposition, of course, for ulnocarpal wrist pain in this series at least. Concerning the diagnosis, as I mentioned, we usually use the Isabella classification, which distinguishes a type 1, a distal type, where you can see the affection of the radius, but more proximally, the radius is quite fine, more or less, and the whole bone type affects the entire bone, including the proximal radius. I've also seen cases with impaction over here in the proximal part, impacting onto the ulna. McCarroll et al. Have done a lot of work to establish deformity parameters, especially the ulnar tilt, the lunate subsidence, etc. So I know that you are well aware of these measurements. We also did a series with Don Bay some years ago and established the reliability of the subsidence method versus the ulnar variance method, and confirmed that the subsidence method is more reliable. Recently, there was also a publication with regards to the capitate related measurement method. So the authors have concluded there's even a high agreement for this method. However, they only included types 1, so the distal types, and the no reference values have been established in this paper. So this needs further studies to corroborate these results. What we know from Madelung deformity with regards to the diagnosis is that there's a spectrum. So there's not one Madelung deformity, but there is a mild to severe deformity. You can see here in this paper from 2008 that the tilt ranges from 15 to 51 degrees, the subsidence from -10 to 11 degrees, and the same is for the palmar displacement. So you can see here that there is a very large deformity spectrum. And also, and this is a very interesting paper, a wide overlap between what is normal and what is pathologic. So you can see in the charts over here that there were very similar values for both the Madelung cases and the normal cases with a wide overlap. So a follow-up study of this paper has established then the more or less threshold values on when to call it a Madelung, or when you are allowed to call it a Madelung deformity. And there was the ulnar tilt cutoff of 33 degrees, the lunate subsidence of 4 millimeters, fossa angle 40 degrees, and palmar displacement 20 millimeters. So at least in this study, these were the values when the 4 observers unanimously agreed on the Madelung deformity classification, not classification, on whether it was a Madelung or actually it was not a Madelung. But there exist mild forms as well, as I mentioned. So in this case, we would most likely agree that there is a Madelung. But how about this case? So a young adult case with a very steep radius plateau. Was it a Madelung? Was it not a Madelung? We actually don't know. And quite often we see young adult patients with wrist pain, unspecific wrist pain, and these images. So this was a cause for me to do a study to establish the reliability among a big group of hand surgeons, signs of variation group, and there we found in these cases out of the overlap zone that there was just a very slight inter-observer agreement among these cases. So we cannot really reliably establish the definition of a mild deformity. So this is unreliable. So they may exist, but it's very difficult to say whether or not these are mild Madelung cases. So there's an ongoing discussion also with regards to the treatment. So this is of course my bias and my recommendation. The optimal age depends on the clinical symptoms. So if the children are younger, let's say up to 10 years, a physiolysis with or without Wicker's resection might be the best option to prevent the deformity to progress. Moreover, the radius dome osteotomy is a very elegant method to realign the distal radius and to correct the deformity. And an epiphysiodesis of the radius and ulna can be added, and also ulnar shortening osteotomy might be necessary. So with regards to the physiolysis, there's the classic paper of Vickers and Nielsen, and I'm pretty sure all of you know this paper. Where you resect the obliterated physis. In the original report, there was fat interposition, which I regularly do not perform, and I have had good experience with that actually. 11 patients with 15 wrists were operated in this series. All had reduced pain, no progression of deformity, and improvement of deformity parameters actually. So this is the classic paper. This is an image of my cases where I resected this part of the physis. And then there's the distal radius dome osteotomy, originally described by Harley in 2006. The advantage of this technique briefly is that you can really realign the distal radius deformity very elegantly, both in the AP and in the lateral projection. And you can also have some kind of lengthening, a little bit of lengthening, because if you slide the distal radius fragment more distally, you can gain a few millimeters of length. So I like this feature as well. And in this report, all 18 patients had reduced pain, improved appearance, and also improved motion of their wrist joint. And also this procedure stood the test of time with regards to long-term follow-up. The Steinman paper confirmed that there was no change in radial inclination over time and significant improvements in wrist flexion. But what we have indeed seen is that the worse the disease was beforehand, the worse the outcome scores at the end have been. So this is an important factor to consider. With regards to ulnar shortening, this is another osteotomy which might be necessary to correct the ulnar variance and to reduce the distal radial joint. There are lots of papers which show the positive results of ulnar shortening osteotomy in this disease. The question is, when do you need to shorten the ulnar? And this was also a paper done with the Boston guys a few years ago. And we have checked the cases which needed a secondary ulnar shortening. So the cases which progressed to ongoing wrist pain due to ulnar-sided wrist pain. And we have seen that especially, it was an interesting finding that the progressive palmar displacement was a predictive factor for the need of a secondary ulnar shortening. And our secondary study aim was related to the ulnar epiphysiodesis. And here we have seen that the ulnar epiphysiodesis was very effective. So all cases which had a primary ulnar epiphysiodesis did not need any shortening later. And all 5 cases which needed a secondary shortening had no prior arrests, so no ulnar epiphysiodesis. So this was very important to show that ulnar epiphysiodesis is a very important factor to consider. The predictors, at least in the Boston cohort for a primary ulnar shortening, were 5 millimeters of positive ulnar variance, 4 millimeters of lunate subsidence, and 22 millimeter of palmar displacement. But of course, the external validity of these results is limited to this specific cohort and region. So we concluded then that below 10 years of age, the ulnar growth can be watched, but in cases 10 to 14 years of age, ulnar epiphysiodesis is warranted. This was an algorithm we then established with our data. I'm sorry, I don't know what the scratches are here. Please excuse, I don't know where they come from. So this is a case example. So at least I can tell you it's not from my computer. So this is a case example with the Madelung deformity, ulnar positive variance, huge palmar displacement. In this case, received dome osteotomy and ulnar shortening osteotomy, as you can see here. Thank you, Francisco. So what are the alternatives so far? We have other techniques addressing the radius, such as reverse wedge osteotomy, like in this report, which has been described only for adult cases. We have techniques with external fixation, which may definitely work as well. So we know that they work, but mostly these are small case series. We have, let's say, case reports with salvage rescue methods to address Madelung deformity, like in this case, or also the Soveka-Panji procedure has been performed in Madelung cases, showing actually good results, like good grip strength, DASH scores with 18 points. So it's really not bad. But I think the future perspective and the main question is related to early physeal detethering and early physeal repair. So you can see here siblings, 2 girls, which I see frequently in my office as well. So a girl with Madelung deformity and her younger sister. So the question is really, is early detethering warranted in cases which might have a Wickers ligament and might have a Madelung deformity, but which has not established yet because they are like 7, 8 years old and not during the growth spurt already. So what we also have seen is 3D simulated and printed techniques, which have been used nowadays by some groups. So this is also a future perspective, which might help us to have an even better, even more precise correction than with a freehand dome osteotomy. Actually, in my hands, I think it works very well, but of course, precision can be enhanced with these 3D techniques. This has to be acknowledged. And also the question is what happens in the long term with regards to osteoarthritis. So in this paper in 2007, the authors have concluded that there was no osteoarthritis in Madelung cases, but they have been operated on, and it were just a few cases, and the osteoarthritis was not really graded classically. So there are lots of questions with not only the main question, but with regards to this paper from 2007. So this is a question: what happens to patients when they are adults and have Madelung, untreated severe Madelung deformity? So this is another thing to be followed by future studies. So my personal take-home messages are, I think, early physiolysis and early epiphysiodesis of the ulna are warranted and are very hot procedures, and also the radiostoma osteotomy. Early diagnosis so far is yet difficult, especially what happens with isolated Madelung cases, because lots of patients have Larry-Weil syndrome, but definitely not all of them. So how to establish an early diagnosis? And literature currently lacks a clear treatment-oriented classification. So this is a problem because as you have seen, there's a lot of bias of all surgeons who treat Madelung. So there's no algorithm, no proved algorithm in the literature. And several methods have not had so far reliable long-term results. So I think from our perspective, especially the dome osteotomy has good long-term results. And I think also the ulnar shortening osteotomy, but several other techniques, they lack long-term results. So thank you again for this presentation, and I wish you a nice, let's say, hopefully COVID-free Christmas time for all of you. Thank you.
Thank you.
Thank you, Sebastian. That was a great talk, and it's great to hear from somebody who's published so many things and has such a knowledge, an in-depth knowledge of Madelung's deformity. So I have a couple questions. Before I get to sort of my questions, I'll ask questions from the audience. There was some. I think there's a few questions about how to or when to perform a physiolysis or the sort of Vickers procedure. And you mentioned from 10 to 14, but then you also use the word early. So, and then there's the issue of sort of siblings. When you see somebody who has Madelungs and they're pretty advanced, but their sibling shows maybe minor radiographic evidence, again, very difficult to tell the very mild cases. Are you aggressive on the siblings? And do you do those earlier? Are you committed to this 10 to 14 age group?
Yes, so if I see the cases which need surgery and they are older than 10 years, I usually go for an ulnar epiphysiodesis. So all above 10 years, they will receive an ulnar epiphysiodesis. And with regards to the siblings, there's some kind of, I think, an ethical issue, because if you see the siblings, or even if you just hear that these cases have siblings, you need, or you might need to pull them to an X-ray. So what I usually do is to tell the parents, listen, there might be also Madelung deformity in her sister or his sister. We might need to consider to check it once, to have an X-ray to see if the X-ray looks a bit abnormal or not. But then, of course, if we have an X-ray which looks a bit abnormal, you can go for an MRI. You can check, is there a Vickers or is there no Vickers? But the real question is, should we operate on this girl if she indeed has a Vickers? And it's an ethical question, because she has no pain, but no deformity, no pain, nothing. But we know in 2 to 3 years, let's say she's 8 years old, we know in 2 to 3 years, she will develop most likely deformity. So that's why I said a little bit provocatively, is early physiolysis warranted? This was related to the siblings, for example. Yeah. I don't know if it answers the question properly.
Yeah. So I guess the question is, if you see a more than a mild deformity, or if you see an obvious Madelung's, is it then too late? Have the cartilage changes already happened? And so I mean, I've seen kids who were less than 10 years of age with whole bone severe deformities already, where they had an older sibling, and I saw both of them at the same time. I saw one girl who was, I think, 9 years old, and the brother was like 12, 14, something like that. And she was one of the most severe deformities I've ever treated, and her brother's was just as bad. And so the question is it too late if you're already seeing the changes, and should we be more aggressive? And I see your point. It is a sort of an ethical question. But if we believe that the Madelung's is caused by the Vickers ligament, and you get an MRI just give you a case example, in a 8-year-old, the older brother has a severe deformity. The sister has a not yet significant deformity, maybe a subtlety. You see some mild difference on the X-ray, and you get an MRI, and there's a Vickers ligament. Are you going to go after that tomorrow? Let's say you see that.
I would have an open discussion with the family and would tell them that this will likely progress to a severe Madelung deformity, or at least to a disabling form of a deformed wrist joint. So call it whatsoever, but I would have an open discussion and tell them, listen, your child today is free of any symptoms, free of any problems, but the longer you wait, the more problems you will get. And just 2 or 3 weeks ago, I've seen a case which was at another hand center in Austria, and it was a very severe type of Madelung's, and the colleagues just recommended to wait until the growth has stopped. And it was very difficult for me to explain to the mother that this was actually not the right decision, because we have to intervene before it becomes so worse like it is. And yes, but I would have an open discussion with the family and tell them I would go for it, because it will prevent a lot of trouble.
Yeah, so maybe we think of it like an appendix. You may be taking out more than you need, but because the consequences are so dire to the wrist, even long term, and I disagree with those articles. I've seen adult radiographs, and I've seen adult patients with degenerative changes in the wrist. So that does happen. And I think to quote Roger Cornwall, absence of evidence does not mean evidence of absence. The fact that they had 5 patients that didn't have arthritis does not mean that arthritis doesn't happen.
Yes.
Yeah. So the other question is around guided growth, and whether or not there's a role for perhaps stopping the growth on the radial side of the radius, on the styloid side, or I should say putting in a plate or something temporarily to limit growth. Have you ever done that?
No, I have just done guided growth in hereditary exostosis cases. I've done it, but not in Madelung cases. So what I usually do is, if I have a severely distorted distal radius, I just add an epiphysodesis of the radius, because you cannot count on a proper growth. So neither with regards to the longitudinal growth and with regards to keeping your correction, it's very unreliable. So I drill the physis and just stop it, because it's not working properly. So it will do a lot of trouble in the future.
Yeah, I completely agree with you. I think in order for guided growth to work, you need to have a reliable growth from the other side that you're trying to get to grow. And given that the Madelung's is already taken out, that's the ulnar side of the radial physis. Just stopping the growth temporarily on the radial side isn't going to do anything. So I completely agree with you. I think there's also a lot of question about 3D printing and how to deal with a whole bone deformity and more severe Madelung's. and whether you address the bowing of the radius as well, perhaps with a second osteotomy or in some other way.
Yes, I have done very few cases. I don't know whether it was one or two where I did the second osteotomy, but usually even in a severe type, I just do a distal osteotomy, one osteotomy, and this usually works well. I mean, you might have some small bowing of the forearm left on the radial side, but this has no functional relevance in my opinion. So I think one osteotomy is usually enough. I don't know whether the audience or the faculty has other experience with that, but at least in my experience, one osteotomy is usually enough.
Yeah, and we've done quite a few 3D model cases. At this point, it's right now in the works of hopefully about to be published soon. We'll see. But when you do the 3D modeling, and it may be a bias to your point, it may not be a functional concern, but it certainly is an anatomic issue, is to do a pretty much mid-shaft radial osteotomy to correct the bow. We found that it's very difficult to get a correction with just a distal radial osteotomy, and that when you correct the bow, it sometimes saves you from doing an osteotomy of the ulna because you get more length out of the radius. Does that make sense? Because you're taking a very bowed radius and you're making it straighter with an osteotomy.
And so how do you correct the distal tilt of the plateau?
With a separate osteotomy.
With a separate, so okay,
yeah.
2-level osteotomy.
So most of the 3D and admittedly, the ones that we've done 3D modeling for are ones that have a 90-degree deformity distally. So these are not your subtle. This is where the hand is pointing sideways. So in those cases where you have whole bone involvement, we found a mid-shaft osteotomy to be very helpful. But I don't think that I could do that case without 3D modeling. I don't think I have the eye to be able to plan that osteotomy as well as we can with 3D modeling.
In those whole forms, if you do a distal correction, that's my experience, you lose rotation, forearm rotation. So I don't operate those children because I don't know how to solve them.
But you leave them with their hand pointing sideways.
With I mean, when there is associated this whole radius deformity.
Yeah.
If you do the distal correction, you can lose rotation. So
yeah.
So I agree with you. So those cases, I don't operate them because I don't know if I'm not able to obtain a good result.
Yeah, I think the 3D modeling is the key.
Yeah.
And I think that one of the things that we found, and Scott, you can correct me if I'm wrong, but one of the things we found is that even though you may line up the DRUJ on your 3D model, that doesn't always happen. And the DRUJ remains dislocated even after you correct the entire deformity in such a way that would allow the joint to come back. And we have done also in some of those cases interposition arthroplasties where we put a piece of Achilles tendon in between the DRUJ because there is no joint left and there's no way to reconstruct that joint. And we have had improvements in forearm motion from those surgeries, but not reliable by any means. Yeah. Anything else to add, Scott? You're muted.
I think, yeah, one quick thing. I think the benefit of the 3D modeling is you can sometimes learn that you can't correct the entire deformity, especially in the whole bone. So we note, because you do the virtual surgery and sometimes you realize you can't correct the entire deformity at all. So you may just want to partially correct it to get some improvement rather than correct the entire deformity. Because if it's off 90 degrees and you correct it 45 degrees, that may be adequate for that patient, especially if they're bilateral, to have an acceptable outcome.
That's correct. Yeah.
All right. Sebastian, any other thoughts? And let me see if I have any more questions coming from the. No, that's about it. Any other thoughts about those comments?
No, I read the papers about the 3D printing, and I'm keen to see what your findings will be in the future. And this is definitely a hot topic for the future for us to think about these 3D printed methodologies. I mean, mainly for the severe types, I would think of, not for the usual common normal type.
Yeah, I think that's fair.
Hey, Dan, why don't you just talk about the smile versus the frown and see if that makes a difference?
Oh, yeah, it'd be interesting to see if anyone's doing that. One of the things that we started doing after, so if you look at your the dome osteotomy and the way that the Boston group does it, the way that the Scottish Rite group described it, Peter Waters says, smiley face and you'll be happy. So meaning it's the osteotomy has the apex proximal for your dome. We found that when we were doing that, occasionally we would get into the DRUJ. So we started doing the, and we couldn't get as distal on the osteotomy. So what we started doing was a frowny face osteotomy to see if we could then make it more distal, but still stay out of the DRUJ. And we've been very happy with that. We're looking into the results of our series to compare with historical series. But I'm wondering if anyone else is doing that in the audience, doing a upside down osteotomy, which Peter Waters says is terrible and no one should ever do. Does anyone in the audience have? So it's just the two of us who are crazy enough to try it.
I have actually done it for another case. It was not a Madelung case. It was some other deformity, and I have had the experience that it hinged very easily. So it got hinged, and maybe it was some technical error, but it just hinged, and it was not so comfortable to do it. And I think I have not had the issue with the DRUJ, so I've never had that problem. But I think it's very nice that you can slide your distal fragment a bit, so you gain a few millimeters. So if the length variance is just 1-2 millimeters, you don't need the ulnar shortening osteotomy, because you can slide the fragment a little bit. There's still a lot of purchase and good bony contact, but you gain a little bit of length. So I think this is the fact I like a lot in the concave osteotomy type.
Yeah, it's a bit like a teeter-totter or a seesaw. You're losing length on the radial side and gaining length on the ulnar side. You're not gaining overall length, but you're kind of doing this by going around the dome. And I think that gives you, it does avoid doing an ulnar osteotomy in many cases, because you're raising the ulnar side, but you're also lowering the radial side, which is what you want. I mean, I'm not saying that's a negative, that's a positive consequence. You're taking a negative and making it into a positive.
Agree, yeah.
Yeah.
And Sebastian, you're right. When you do the frown, you have to take down a little bit of the radial bone or you will hinge. Just like Paco, just like when you do a dome for a humerus, for cubitus varus, you have to take down a little bit of that corner to get it around the corner, else you will hinge.
Yeah. Okay.
Okay.
I think that was a great talk, Sebastian. Thank you so much.
You're welcome. Thanks.
Thank you, Sebastian. Thank you, Dan. So great day today, as usual.
Yeah.
Should we say goodbye?
Until next time.
Yes. Until next second Sunday of the month. After Christmas.
Right.
With a bigger belly. Ciao.
With a jamón.
Jamón, sí. Adiós.